Yeah,
recording.
I'll probably do that another time.
Yeah, yeah, I'm recording, but I haven't started sharing live yet. It's going live in 3, 2, 1. Okay, so we're live right now, but hang on a sec. Let me get in here and share this out. If I can figure out how to do it. Uh, okay, I'm going to do it on my computer, my other computer. So, Steve, before we even begin, you're in New York, aren't you?
I am the epicenter of this COVID-19.
Yeah, so fill us in on that. What's going on? Like, what have you been experiencing?
A lot of alone time.
Uh-huh.
It is what it is. I mean, it's crazy. I mean, it's one of the reasons that this topic is important is because our lives change so much with this one event. People that never thought that they would see this in their lifetime, where the whole world is affected by a virus that spread very quickly, very fast, and is deadly in a lot of places. So with New York, they closed down schools for 5 weeks about a week ago,
Okay.
which was a big, there was a lot of people saying, what are they going to do, kids, and babysitting and everything. But that's the smartest decision I think to do, because people do have to kind of be isolated. People are still going to parks. People are still outside. You see them running. I actually had to drive out to Brooklyn over the weekend, and it was like business as usual there. And it's interesting because people have a different take on this, and I think eventually they're gonna do patrolling to get people off the streets, but who knows? We just
Yeah,
have to be safe. And
there was a rumor here locally. I don't know if you've heard anything, Will, that the local health department went into a place. It was a mom and pop butcher shop
hmm
that was packed. I mean, it's always packed, and they were packed.
yeah,
That people couldn't buy meats at Kroger, and so they went in and they shut them down. But it was the health department that actually ended up doing it,
yeah,
because all public business, minus Kroger and necessities are closed.
right, exactly. They had a wedding over the weekend in my city as
Uh,
well. So, and that was a big headline across the nation. So you know, you don't know. Some people are taking it seriously. Some people are saying it's going to pass. It will pass eventually, but are we going to do anything to make it stop faster? That's
right.
really the question.
Yeah, I mean, and this is a chance for people to step up and do something. And the way it should feel if we do it correctly is we should feel like we just wasted this time. Like, oh man, nothing happened. Like that's like the best possible outcome, because
hmm
that means we prevented it from doing that. But I know personally, I've got a mentor. Well, I've known him for a long time, and at one point he was a mentor. His father is they're actually preparing. They're preparing the family for his father to potentially pass because he's 70,
Wow.
comorbidities, COPD, diabetes, and tested positive for COVID,
Wow.
and is not responding well, 100% oxygen, those types of things. And that's the reality, like that's there. But just because we're not so interconnected as people that we feel every insult to a community, but like the only way to get ahead of these types of things is by taking on ourselves a little bit of social responsibility and kind of bite the bullet and those types of things. And I wish I was more well read on some of the things that the government is attempting to do. But from what I have read, what I've skimmed, and what I've headline ingested, it's kind of frustrating.
Yeah.
Yeah.
Well,
Yeah.
Will, before we start, Will, you asked me, and I'm sure a lot of people are wondering too. I've been looking for a time to discuss it, what we are doing. So
Yeah. What's your
here's the
practice doing?
situation. We officially shut down pretty much all patient care sometime late last week. The governor put out his announcement over the weekend. I think it might have been Sunday. And we had already discontinued care for all, high-risk individuals that didn't really need direct services. So, we still had some post-op cases that we were treating. It was all one-on-one in the clinic. Nobody else was in the clinic, one patient at a time, and just me. We fortunately kind of saw this coming 2 weeks ago. So as soon as the governor came on with one of the first announcements, I talked to my team and I said, hey guys, look, here's the situation. This is what's coming down the road. We're not going to have patients in the clinic. They're relaxing the rules on unemployment. Let's take advantage. There's a reason why we pay for unemployment insurance. It would be like me breaking a leg, having health insurance, and not wanting to use it. So I talked to my team, my clinical staff. I said, hey guys, file your unemployment claim today because we know what's coming down the road. I will take care of you no matter what happens. If it doesn't process, we'll be covered. But let's conserve the resources we have. Get on, unemployment now, and let's see where it goes. And sure enough, I think there were 12,000 claims filed that day, and then all of a sudden it was like 75,000 claims and up. The system just got overwhelmed. But the interesting thing from a business perspective, and I don't mean to ruffle feathers, but I think it's important for us to understand this, is as a clinician, of course, we feel high and mighty, all important. We say, how can there be patient care without clinicians? But when push came to shove, the reality is the clinical staff were the first to go, no matter how much I love them, how much a part of my team, my family, how important they were. They were the first to go. My admin individuals, really two, I couldn't let them go. Like, they were working from home. They had computer access. Nobody was coming into the clinic, but I needed them to continue processing claims, continue to have the revenue flow coming. So it's just interesting. I mean, I'm a clinician, but I go back to that Rich Dad, Poor Dad book where it talks about anytime you have a job, no matter how amazing the job is, you have to understand you're the first to go until you become the business owner. Now, I'm the last man standing because I own the business, and there's still things that I can do to generate income without direct patient contact. But yeah, that was interesting. So that's where we are as an organization.
That's good.
Staff got laid off, but they're on unemployment. Administrative staff continues to work from home remotely into the system. And that kind of brings us to the topic of you and HelloNote and some of the new developments that are coming out with HelloNote. So fill us in.
Yeah, thanks, Tony. That was well said. It's good to hear that you are protecting your workers, because I have heard other companies told them don't file for unemployment because they knew their rates would go up. So that's not something you want to hear from your employer. So it's good to hear that you are protecting your employees. And also, as you said, now everyone has an option to work from home, which does bring us into the topic of automation and how technology is around us and we don't even realize it. So with HelloNote, we opened up our patient portal earlier this year. So I mean, I don't want to use this COVID as a positive thing, but it happened to be at around the same time that we opened up our patient portal with Telehealth, and we've had a influx of users just reaching out and saying like, do you have Telehealth? Do you have Telehealth? And we do, so we sign them up. Because as clinicians, we want to maintain and continue that kind of care for the patient that we worked so hard to get to where they are now, right? So it's very upsetting for clinicians to know that they work for somebody for weeks, months, even for some people years, and to know that if they don't get that same care on a consistent basis, that they're going to decline. And now all that work might have been lost. So with the development of telehealth with HelloNote, so we brought that out there. Why? Because we just wanted to keep up with the changing industry of healthcare. So now, telehealth.
This was obviously something that's been in the works. It's not like you guys found out Monday COVID problem and then Tuesday you rolled out a virtual platform. So kind of tell me what's been going on behind the scenes leading up to this.
Behind the scenes, it was a lot of pressure and a lot of work, because telehealth was something that was brewing for at least I want to say like 2 years. It was something that we had thought about, we were getting requests, and it's a lot of work. It's not something, as you said, it's not something you could just flip a switch and here's telehealth. You
Right.
know, there's a lot of key players in our team that we're very thankful for, that are working to keep the system up and running, to produce everything they have to make sure that patient care and documentation is flowing. So yeah, it's not a switch that we just said, here's telehealth, here you go. There was a lot of work involved, and we did meet our time frame where we wanted to bring it out. So it was a little later than the first of the year, but it was, you know, kind of within what we wanted it. So it came in at a good time, because now a lot of clinicians are using our system for telehealth and those e-visits as well. I know that these e-visits are not replacing telehealth, because they're minutes that you can bill over the course of 7 consecutive days, and then you have to aggregate those minutes, correct, and then bill that once you're done with your 7 days. Is that correct, Tony?
So, you know, I differ from Nancy and Rick, but to the best of my knowledge, and just for those of you listening that you're still kind of trying to find guidelines, APTA at least published an FAQ that I'll share in the comments here in a little bit. But basically, everybody needs to understand there's a distinction between an e-visit as defined by the CPT code, and there's 3 CPT codes that correspond to different aggregate minutes, how many total minutes you're providing this e-visit. That is different than telehealth. So telehealth in our terminology would be associated with, you know, a physical therapy, occupational therapy, speech eval, then treatment rendered and all of that. The e-visit is more kind of a contact initiated by the beneficiary. The patient has to be a patient of your practice already. And then with that, I'm sorry, got guys crawling behind me. With that, you need to total the minutes within a 7-day period. So if I see, you know, a patient, Mrs. Smith, on Monday, she was a patient in my clinic the week before. Monday hits, I can't see her in person. She initiates a contact through a portal, which you're going to tell me more about, HelloNote's portal. I do 5 minutes. I'm like, hey, you know, Mrs. Smith, how are you doing? How's everything looking? Can I see you do it? Okay, that looks great. Keep doing those, add these. I'm going to catch up with you on Wednesday. Wednesday, I do another 5 minutes. Friday, I do a 10-minute kind of all-encompassing. My total minutes in a 7-day period is 20. I submit the CPT code for the e-visit with the modifiers, and APTA's FAQ has the modifiers you need, for the total of 20 minutes, whichever of the 3 CPT codes corresponds to that. So that's kind of in a nutshell what we've got, but I'm not billing 97110 or 530 or any other codes. It's just I think it's a G code for the e-visit. So tell me about your portal now. Is there video? Like, is it just communication? How does this work?
Yeah, so the portal, so I want to differentiate portal from telehealth, because just because you have a portal does not mean you offer telehealth.
Right.
So what we wanted to do is bring both to the market at the same time, because, you know, we always want to bring something to the market that's unique and something that's very user-friendly and an all-in-one system. So just bringing patient portal was not enough for us to just say, here it is, because if we could have done that last year. We could have just brought a patient portal, but that telehealth component to us was a dimension of the industry that we wanted to tie in together, and I'll tell you why. So initially, when people think patient portal, what does it mean? It just means a patient can access a portion of the EMR or EHR and see their information. That's really what a portal is. So with HelloNote, the way we designed it was to allow the patient to log in to a secure portal, and then they can actually put in intake forms. So if, for example, it's a new patient, you can already have them fill in all that information that you were going to get from them anyway. So they can do it from their phone, from the tablet at home, without having to waste time sitting in a clinic waiting for for the receptionist to give the paperwork to them. You could also book appointments online. So if you wanted to request an appointment, the patient can do that, and then it would be up to the therapist or administrator to approve, deny that, and contact them if there's any modifications. Paying your bill, that's another big thing. So right now, a big industry is merchant services, right? Credit cards. So you want to make sure that patients can take care of a bill from their home before they go to see you maybe, or after their session or during. So that's also included. And another big one is consent forms. We include consent forms in our system because a lot of times, especially new practitioners that are opening up their own clinic, and we niche in mobile practices, they don't know what forms need to be signed. So we include that for you. It auto-populates your clinic name, the date, the patient name, and then the patient has a place to sign their name. So this way they get a copy and you get a copy. So that portal holds that information and is accessible to the patient and to the clinic.
I missed
And
it. Was it an e-signature, or is this they print it, sign it, and then upload it?
all electronic. So they don't have to print anything, which is a possibility. They can print something and upload it into our system as well. But because we brought a portal to our system, we needed it to be an actual portal function. So they can actually sign it right from their phone, from their tablet, from their computer, and it uploads right into the cloud that we use for storage, so they can retain that.
Question: within the portal, is there the capability of the client taking a picture on their phone of their insurance cards and uploading those images securely directly to the system?
Absolutely, yes. So that is, so we also have kind of like an e-filing cabinet where patients can take pictures, PDFs, and then upload it into our system. And then it's accessible by the clinic.
And so then obviously they'd be capable of snapping a picture of their referral if it's a piece of paper, snapping a picture of an MRI report or other imaging, snapping a picture of past medical history, not past medical history, medication list, all of that, just snapping away, uploading those images.
Yeah, exactly. And that ties into our automation topic, because, the patient is included in the automation process. And Tony, I remember when we first spoke, and I showed you HelloNote, and you asked me about, can the patient fill in their medical history in HelloNote? So that was a great point. And in our case right now, patient can actually upload any forms that they have or medical histories. So yeah, that's definitely something that's possible in our new portal. And the highlight of the portal, of course, for many is telehealth. So telehealth, the way it works is the therapist has to initiate the session, and once they initiate the session, the patient will be able to join in on that session. So this way it's secure. This way the patient doesn't open a session and then, who knows who's going to access that. Yeah. So therapist initiates it. And then, of course, they have a time slot that they would book, and then the patient would be able to click join, and then it would open up a window for them to join. And we also use Microsoft for our telehealth platform.
I was wondering about that. So you use Microsoft for the video hosting or whatever, I don't know the terminology.
Yeah, it's Microsoft Teams. So it's another, version of GoToMeeting, Zoom, and so on. So we rely on them. So far, it's been fantastic feedback as far as the quality and ease of use, which is what we were, for us, everything's all about making it user-friendly and easy to use and intuitive. So, so far, it's been great, positive feedback. And the reason why is because you can join through the web without downloading anything, or you can take it a step further by downloading the app, and then you have the capability to do like screen sharing and things like that. So that's a huge component to some clinicians because they want to be able to, for example, home exercise, program. They want to be able to share their screen and go over it together. And they can do that by sharing their screen and at the same time seeing the patient. So if a patient wanted to, simulate the exercise, you can actually see them do that and then go over any details in the plan that you have.
Will, I don't want to cut you off. As soon as whenever you need to, just stop me. Steven, go back for a second. So you talked about automation. You talked about the client essentially being involved in the process. I don't know if I missed it because I was typing and I want to hear this. I want to make sure I understand. So tell me that again. Is there a situation where first question, is
Yeah.
the potential client able to reach out to the clinician first, or does the client have to have an invitation from the clinician going out first?
Yeah, good question. So especially with e-visits, I think the regulation is that the client has to reach out first.
Supposed to
So
be initiated by the person, but I'm more interested in your system. Forget telehealth for just a second. I'm really curious because one of the issues that came up for me in other EMRs was I wanted a way that a stranger could see my content, go to my website, go to my social, and say, hey, I want to schedule an appointment with Tony. I want that stranger to be able to initiate the contact with me through the system. Previous EMRs, and yours might not be able to do that, and that's totally fine. Previous EMRs weren't able to do that. I had to initiate, create the account, then send an invitation to the individual. I didn't know if there was an opportunity the individual could initiate the contact with me through HelloNote.
yeah, well, I like answering yes to your question. So yes, they can do that. They can actually, they can initiate the booking. They select the therapist they want to book with, the time slot, the date, and what type of visit. So it would be up to the clinic, of course, to set up the visit types, and everything's customizable, of course. So they could do, you could have a visit like telehealth. So then the patient through the portal can initiate that, and then you would get a notification on your side, and then you can go ahead and start the session.
See, that's huge value because before what I would have to do is I'd create a landing page. I would have to say connect with MailChimp and then put a form on my landing page with MailChimp. Then an individual would reach out to me through MailChimp. They would opt into the landing page, go to MailChimp. From MailChimp, it would get notified to me. Then I'd have to put it in my EMR. Then my EMR would send them another invitation. So it was HIPAA compliant. Just crazy stuff.
Yeah.
But you're essentially saying I could embed something from HelloNote on a website that would allow the end user, the client, to initiate the contact right there. As long as I set the visits up and whatever it's going to be on my end.
Correct.
Awesome.
Oh, that's great.
Go ahead, Will. Ask your question. I'm going to close these doors.
All right.
Yeah.
No, I just think that's fantastic because I think that integrates well with what a lot of people are trying to do with telehealth now is they're creating these funnelings and putting out why they provide a unique service, and then they still have to be there to baby step somebody through to the finish line. Whereas if they're able to put it out, I don't know. I like that. They don't have to divide their attention to begin to onboard somebody.
Yeah, it's definitely. And we also help with that. So a lot of our clients reach out and, someone designed their website and they lost contact with them. So we actually step in and we can configure a plugin for a contact form for them. And we do that plenty of times. It's part of our setup process. We want to make sure that, if a user signs up to HelloNote, they have a positive experience and they don't pay any setup fees. And we actually get them going as soon as possible and as seamless as possible. So we do have clients that switch from other EMRs to us, and we want to have a good value proposition on our end. We don't want them to switch and then have a hard time adjusting, which unfortunately that's how it is. I mean, you have to adjust with any system that you're going to go with. So we do our best to make it as streamlined as possible and seamless as possible. So communication is key. So as long as you communicate with us, then we'll take care of it.
Let me ask you, go back a second. You mentioned credit card processing. You have an integrated method to do that. I'm asking, and who handles that? Like, do you go through PayPal or Stripe, or tell me a little bit more about that.
Mm-hmm. So we have an integration with Card Connect.
Okay.
They're owned by First Data, but they're a subsection, which is great because they actually niche in PT, OT, and speech.
Sure.
So which is one of the reasons we chose them. Say that again.
That's Tom you're working with.
Tom Cooley, yeah, exactly. So we thought it was a great fit because they niche in the same field that we niche in. So we picked them as a partner, and they also they work well with our members, and any pricing that they would that a competitor would offer percentage wise, they would make sure that they either match it or beat it. So we have that agreement between them, because we don't charge extra for this integration. Again, we want to provide an all-in-one solution at a fair cost. So we don't charge extra, but at the same time, we want to make sure that the company we work with works well with our clients, because if they're managing your money, we want to make sure that they're doing a good job and you get paid what you deserve. So.
Sure. I mean, I've heard nothing but great things about Tom. I've talked to Tom personally in the past. He seems like a very stand-up guy and represents a great company. So, I don't think anything about that. How is the process? Because I want to talk a little more about the billing side of HelloNote, the billing integration. Now, I understand, because we've had this combo, but it's important for the community to hear it. When I did the demo with you, there was a hidden gem in there that I don't think you emphasize enough. And I don't know if you don't emphasize it because you're just so used to it, or you don't necessarily realize how important it is to so many other people. So you guys are connected with Ability, Ability.
Yeah,
as the integrated clearinghouse. And the integration was great, and I love it, and I think it's awesome. But you and I discussed this. They do a package through you where it's a certain number of claims per month. And so it doesn't matter how many rendering providers you have, you're doing a number of claims per month. But a new startup, like I was just talking to someone again the other day, where they're working with a bunch of individual clinicians, none of whom are seeing high volume in any capacity, but they've got 10 clinicians working for them across PT, OT, SLP, all just generating a tiny handful of claims in a month. And so with Office Ally, that is a negative, because Office Ally would charge them $35 for each one of those clinicians, even if they just submit one claim.
Right.
Ability, it's a better option. But now the flip side of that is Office Ally charges $35 per user rendering provider for unlimited claims in a month. So, there's times to go with Ability, there's times to go with Office Ally, times to go with Availity and all the others. You guys in your platform have the capability, I should say, of exporting the claims file, the 837 claims file, and the user can upload it to whatever clearinghouse they want.
Correct. Yes. And that's one of the reasons.
And you have the ability to download and import the 835, which is the electronic payment remit. So there's huge functionality in that, because no user is tied to a single clearinghouse. Even though you guys have a great relationship with one, doesn't mean your users have to use that one.
100%. Yep, exactly. And that's one of the reasons we designed it that way, is because we didn't want users to feel locked in. Like, for example, we have users switching EMRs, but they want to keep their clearinghouse. So we don't want them to make them feel like they have to do both. Like, it's not an all-in-one. If you want to use us for EMR, fantastic. You can use your own clearinghouse, no problem. And you don't have to pay anything. It's completely free. We give you access through our practice management side to download that 837 file, which you can upload to whichever clearinghouse that you want.
Awesome.
Yeah, I think that's great, because that's an integral part of, especially once you know the system, it's one less learning curve.
That's definitely true. And back to the price point, you're not really, I speak to some people, and I hear from my team as well. Some people make it a big deal that they have to pay, $50 per month to submit, for example, 50 claims per month, right? But you're not, it's related to your time as well, because then you ask them, well, how much are you spending on your other clearinghouse to do data entry? And then they tell you that, they spend 5 hours a week. So that 5 hours a week, you wouldn't even spend a fraction of that with our integration. And if you divide your time, then you're paying yourself like 50 cents an hour to do that.
Yeah, the problem is you're using logic. There goes another one of my guys. You're using logic to justify a buying decision that's completely illogical. It's that person that will drive 20 miles across town to save
cheaper gas
pennies on a gallon of gas.
Yep.
You just can't do it. And I explained to my members in my billing group, I'm like, look, guys, yes, you can save this money and do it manually. You can mail your claims on paper still.
Hmm.
But at the end of the day, you're paying postage and you're spending time licking
Yeah.
envelopes and stamps, and you're never gonna come out ahead. Just pay the price for the electronic claims. But I understand what they're saying, because me too. It's like you do this for $10 and then $15, and you do something else, and you do these, and you have all these little memberships just like bleeding you out in
Yep.
these little tiny increments, and it's just crazy.
Yep.
So I'll never
You know,
blame
it's
somebody for wanting to do certain things themselves and making those decisions.
never. We also, I don't like to like say, no, do it this way. I
Right.
always like to give people an option, but it's up to them to make that decision. And, it always comes back to comfort zone,
Yeah.
because if they're comfortable doing it that way, then, sorry, getting a call come in.
Yeah.
If they're comfortable doing it that way, then, go ahead. I just like to give you options because, essentially, I heard this yesterday. One of my partners shared it with me. You're stepping over dollars to collect pennies, you
Absolutely.
know? So, it's very true. But, if you're already comfortable doing it a certain way, it's very hard to break out of that and say, well, now I'm going to switch it because now I have to learn another system. And that's another thing we do at HelloNote, is that we take care of your training live. We don't send you through like, we don't give you like a little ebook or anything like that. We actually schedule live calls with either myself or my other team members, where we go through the system with you. And if you need more time, we schedule another call. So essentially, we get to a point where our users are comfortable. And everyone has their different learning curve. So, there's nothing wrong with that. So, so it is what it is. We like to offer options, but go back with what you stated. Yes, you are free to use your own clearinghouse or any other billing company, and use our system for EMR and telehealth.
Yeah. Yeah. Now, while people are watching, on the Learn Medicare Billing page, so I shared it from the page into the groups, but on the page itself, I pasted the link to the APTA FAQ on e-visits. Anytime somebody's asking me a question about e-visits, I'm learning just like you guys are. I go to that FAQ. I go to Rick, I go to Nancy, and I go to the APTA. Those are my three sources right now to get reliable information. I also posted a link to HelloNote's website. I will continue to push Steve to get more content out there, get more videos out there, show you guys what the platform looks like, because as much as they do an amazing job on their team, holding your hand and walking you through the challenges, I also want them to be able to give you some behind the scenes footage so you guys can see what it looks like from the inside. Because like anything, if you can't see it, you can't like it, you can't trust it, and you never get on it. But
Right.
there's tremendous, there's just so much value on this platform. And I'm full disclosure, like, I'm not getting anything for this. I'm not promoting it. Like, obviously we'll do interviews with other platform creators. I just know that for the team that you're looking to work with, you guys bend over. I talk to a lot of people who've signed up for your services. No matter how good or anything you claim to be, it's not until you hear the end user say, they just are amazing. They do everything for me. Like, they help me so much. They hold my hand. They walk me through every step in the process. Those are the things that the potential clients need to hear. Okay, I know we lost Will. His computer kind of freaked out. We're at about the 33-minute mark. Was there any other components or anything else you wanted to share related to HelloNote, related to what's going on? You, as a working OT right now, are you doing some e-visits? Are you connecting with any clients online?
Yeah, so of course there's no physical interaction with clients right now, even though we are considered essential. The health and the comorbidities of our patients is not worth the risk to actually bring somebody from the outside into their home, unless it's a life decision for them that they need it. As far as e-visits go, I have reached out to a few of my clients, and of course this is a new topic for me too, e-visits. So I'm trialing it out myself. I will plan to bill for it myself as well, just so I can get feedback. Because as you know, if I don't know how to do it, how could I go and market something without me actually doing it myself.
Yeah.
So I am trying it out. I'm doing those e-visit consultation calls, and also I'm using HelloNote for that. The challenge that I have with that, and is the fact that I'm dealing with the geriatric population. So a lot of them don't have a computer or a smartphone. So a lot of times we have to reach out to the families, and they have to set it up for them. We do our best. Of course, the e-visit is not going to replace you physically being there, and that goes back to my topic of automation, where how much is too much of automation is a good thing. Like when you see a patient, right, and they love the fact that you're there, you're helping them. But if they had an option to see you, so putting the whole coronavirus thing aside, if they had an option to see you electronically versus you actually stepping through their door or seeing them in an office, what would they choose?
Right. I think what's most interesting about that question that you just shared right now, I think anybody watching this right now is going to say they want in person. And I think anybody watching this right now is going to say, and Will, we've discussed this. They're going to say, because I've said it, right? I've been a clinician now too long. And I've said, the most important thing is the human interaction. The most important thing for Mrs. Smith is getting out of her house, or you going to her house and you talking and you sitting and you listening to her and you hear about her grandkids and her cat and the pigeons on the stoop, right? I'm trying to relate to New Yorkers. Like we've all said it and we've all been there and we've all felt that. Problem or opportunity, depending on the way you look at it, those are not covered services, So e-visit aside, telehealth, all that stuff, the stuff that I think we as clinicians have come to value the most are not services payable by Medicare. And we've squeezed them in under the guise of, well, I'm going to listen to your story so I can get you to do 3 more, leg extensions. But the reality is Medicare has clearly said time and time again, those are not reimbursable services. They're not covered services. So that leaves us in a position, good or bad, where we could say, hey, Mrs. Jones, I would love to hear that story about your garden again. Unfortunately, that's not paid for by Medicare. You wouldn't say it in that way, but it's like, these are the things that Medicare will pay me to do with you. But I think these things are just as important and they're not paid by Medicare. But if you would like to do them, this is the cost. And that's where you bring that marriage of, okay, what is Medicare intended for? What are they actually paying for? What are their guidelines cover? And then what are the things that we as clinicians believe are just so vitally important? I think food is more important to my client's well-being than any exercise I could ever give them. Medicare is never going to pay for their grocery bill, right? But that's a component that needs to be in a well-rounded rehab program. So in a hybrid model, Medicare pays for the exercise, the client pays for the nutritional counseling and advice and recommendations and information. And I now just negated the 8% cut coming down the road, the was it 22 or 25% cut for assistance. Like all of these reductions that are coming, they disappear because now I'm actually billing Medicare for what Medicare is intended to pay for. And I'm allowing, important word, allowing my Medicare beneficiary to pay for the services that I, as a professional, think are important. I don't know how I got on that soapbox. Apologies. Will, we were just about to wrap it up before you came back on. But do you have any
that's fine.
thoughts?
Welcome back, Will. A question for you. I wanted to bring up that, so we had a call about a month ago with, clinical judgment and therapists, where we had a pretty good discussion on that, where, therapists at one point, with the automation topic is, at what point do you pause and say, well, I can't automate this treatment. I have to actually be there and use my clinical judgment. So do you remember that topic?
I remember. Yeah, I remember we were talking about it, and some of it was talking about how people are looking to entirely automate their documentation, how they're looking like everything and anything automated, which then makes it difficult to distinguish treatment from treatment. which then like is critical. Like the billing codes, I remember hearing, I can't remember who the billing specialist was. It was a long time ago because I was actually still practicing. But they said ultimately those codes are designed so any other professional anywhere else in the medical system can pick it up and say, oh, these are the types of things that are being done. But it doesn't actually explain the active plan of care. It just kind of said, well, here's what we're trying to address. And I think sometimes the the leap towards automation in hopes to save time, I feel also dilutes the delivery, because if you can get so automated in that, and after an initial eval, all you got to do is punch something in and up pops a plan of care, which then I feel kind of removes us. I shouldn't even say us because I don't practice clinically. That's not a fair alignment.
You're still part of the family.
Yeah, right. I'm the uncle nobody ever talks to or wants to be alone with too long. But that's like, but I think the pursuit of automation, we have to be careful to not push ourselves out professionally, because like that's possible if you put that effort into, if you're trying to make yourself so automatic in what you do day to day as a clinician, you're going to use that flavor that makes you unique. And now where's the specialty? What's being paid for?
Right.
At which point, I don't know, then you can hand it to anybody. And it's kind of, I mean, you see, I haven't thought this one through and we're live, so this could be like a false equivalence, but you kind of see something similar with the nurse anesthetists, where the anesthesiologists have kind of priced themselves out of the market. And next thing you know, they say, well, what if we just have one supervise a number? And you kind of dilute. And I think looking for a system or a program to do more of what we should do professionally, I don't know, we kind of risk the less special we make ourselves, the I don't know, the more at risk I think we are, because not everybody is going to be able to stay in a highly automated system. There's just not going to be a unique value proposition for the average therapist. And if you think COVID's bad, like that's going to cause a lot more problems than COVID.
That's a good point.
I agree. I'm going to jump in here. I agree. But on the flip side, I also say that we have to constantly be trying to push ourselves out of a job, right? The iPhone 4 is not the iPhone 8, is not the iPhone X. So I think the more we automate the stuff that doesn't require the skill of a therapist above the shoulders and between the ears, the more room we have and the more time we have to focus on where our skills are really needed, and that's where you dig deep down and you look at all the clinics out there, just like mine, who have really relatively inappropriate referrals coming in the door. People that are fully independent, fully functional, they're dealing with some persistent pain stuff. We've gotten through the eval, we've gotten through the initial education, the initial programming. Technically, we're done. Like from a Medicare perspective, we're done. Now the client can pay you like a personal trainer to continue to provide motivation and make it interesting and exciting and use all of your clinical advanced skills that you have. But at the end of the day, you're done with that patient. But now if we're talking about a significant, traumatic brain injury diagnosis that has multiple comorbidities, multiple complexities, open wounds, fractures that aren't healing, like that's where we should be focusing on time. So the automation allows us to offload the stuff we really don't need to waste a clinical brain on and put that time into the people who really need it, and I think we would see reimbursement go up, because right now we're seeing reimbursement averaged over everybody we see. So the guy that's being seen for 36 sessions for persistent low back pain is no better on 36 as he was on 3. They're dollar cost averaging our reimbursement against the individual that got hit by a car, traumatic brain injury, and history of, neurologic condition. I think that's where we're shooting ourselves in the foot.
Totally agree.
Right.
Like with that perspective, I think it's great. And you sharpened, and I wouldn't even say swayed my opinion, because a lot of what I'm just doing is just kind of talking out loud as things pass through. But I think that perspective is healthy. So then maybe it's reframing the clinician's mindset to be less focused on leveraging somebody's available benefit and more focused on finding and serving a population. And the argument from their perspective is maybe there's not enough fish in the pond for that. But I would agree. And I think the quicker that we got that persistent 36 visit low back pain out and away from our mindset of that's who our target is, I think that will force the professions to work harder to be better,
Right.
for those who really need it.
Steve, what are your thoughts?
Yeah, I loved hearing both sides. You know, both you know, Will, that you had like one extreme, and then Tony, you brought it back with another. So I mean, and that's where we are as clinicians. So what type of clinician are you? You know, because on both sides you can have a clinician, and I hear it as well all the time. You know, and that's one of the reasons I like this topic, is because as a software engineer and a therapist, I'm ripped between two sides of, here, give me more automation, and no, I want to do more. Just give me, you know, I want to write more. So I love that. And you know, on one side, you can essentially automate yourself out of a job, because if you promote automation too much to the point where it's like, I put in diagnosis codes and I recommend the treatments, click a button, and then it's going to give me a whole care plan. What's the point of you being a therapist? Why go to school? You know, where's the clinical judgment in that? So I do have some therapists asking me for more automation for the wrong reasons. And then, as Tony said, I think it could be a fantastic opportunity for therapists to promote themselves in a way where now we can free up more time to focus more and use our clinical judgment to help others. And then we will see a huge impact in the reimbursements in a positive way, as opposed to what we're seeing now in a negative way.
I mean, I would even equate it like in my world, my outpatient, you know, ortho world, where I could go to a payer and say, look, what if instead of paying me for what I'm trying to justify as medically necessary and, you know, averaging 15, 20, 24 sessions for a specific condition, whatever that condition may be, go to a capitated rate for a lot of these conditions. Give me $800 up front and let me do what I need to do. And if I get readmissions and I have problems and failures and poor outcomes, penalize me, but give me that freedom. Because at the end of the day, for most of the cases I see personally, if you give me more freedom, I can save boatloads of money on the payer side and make boatloads of money on the business side. Now, the reason why I say that is because that gives me more leverage to appropriately choose who I think is the right person for this individual. You know, every individual doesn't need a PT, OT, SLP. They don't even need a PTA, OTA. But if I'm stuck in the mindset that everything has to be medically necessary and paid for by a payer, if I take away and I steal my client's right to choose how and what services they want, how they want them delivered, then I'm stuck. That's the world under the 80% of the bell curve. That's the world for the corporates. That's not the world for us. Athletico does an amazing job. NovaCare does an amazing job. They have the resources, the systems that, you know, that's their world. We need to stay out of their world. We need to be on the 5% extremes, the ends of the bell curve, high cost, high value, or, you know, low cost, moderate value. And the whole idea being that, again, nobody's saying you can't do it. Nobody's saying that you wasted $150,000 on an education. I know you're not saying this. And nobody's saying that you can't go get all these amazing con eds and learn all this stuff and become certified, you know, in manual techniques and dry needling and all this stuff. You can. You just have to understand that's not what the payer is paying for. But the individual client, whether it's a Medicare beneficiary or not, has the freedom to choose. That may be what they want, in which case they deserve to pay for it. You know, if I want a Lamborghini, I'm going to pay for it. If I want a Honda, I'm going to pay for it. Both are cars. You just got to let the consumer decide what the consumer wants. We're just so tunnel vision still in 2020 that we constantly go to either it's all third-party payer or it's all cash-based. There's nothing in between. There's no middle ground. You know, when there's tons of area under the curve. Okay, I'm sorry. Let's wrap this up. We're at 49 minutes. Steven, once again, if anybody wants to reach out to you, reach out and learn more about HelloNote, see videos about you using the platform, what's the best way for them to do that?
They could either go to HelloNote.com or they can reach me at steve@HelloNote.com. I'll be happy to schedule a demo and route you to the appropriate place where you can find out more information.
Awesome.
Well, well said, Tony and Will. And back to wrap it up with telehealth is, we hear a lot of the therapists saying, great, this is a great push for us now to promote telehealth and tell insurance companies to pay for it. So they have to understand the concept that even with e-visits, they have to understand that these CPT codes that you're going to be using, these G code ones, Medicare will be collecting data on them, because they're going to want to see how it's used, over a period of time, and then seeing how that's related to less or more visits. So the actions we take now are very important to what we're going to see in the future with insurance and regulations.
Will, how's the knee doing before we let you go?
It's doing what it's doing. It's just kind of it doesn't hurt and it just kind of hangs there. But we're getting there. I'm using my $150,000 plus education to have just a real snazzy home exercise program.
See, it came in handy.
Yeah, right. It's exactly why I got it for this.
Right.
Just in case.
Yeah, the second tissue rupture, second tendon rupture. I got this.
But still no pain, correct?
Huh?
Still no pain?
No pain. No pain. No function either.
Well,
All right, guys, we're going to wrap it up. If you're still on, there's 12 people watching, 13 people watching live. Thank you guys for watching live. I'm going to keep this video available. Then I'm going to move it over onto the YouTube channel. Go support us on YouTube, subscribe, share. If there's specific content you guys want to see, let us know, whether it's HelloNote specific or general. We're here for you guys. We have lots of time right now. Take advantage of it. This is the time to learn. This is the time to grow, to build your business. If you're going to get on an EMR platform, do it today when you have no patience. Because if you do it when you're busy, you're never going to do it properly. So Steve should be busy nonstop onboarding people right now, because now is the time to build the infrastructure for a real business. All right, guys, I'm going to end the live. You guys hang out. Give me 2 seconds.
Cool. Thank you.
Okay, you guys still there?
Yep.
Still here.
I cannot believe.
Recording.
What's that?
It's still recording.
Yeah.